Welcome back, everyone. Today, we are tackling a truly massive topic in this explainer, the pediatric clinical exam. It can often feel incredibly dense and overwhelming, right? But what if we could distill all that moving information down into one universal, highly structured framework? Well, that's exactly what we're going to do. We're going to build a mental map so that every single time you approach a pediatric patient, you know exactly what to look for, step by step.
And it all starts with this incredibly helpful little mnemonic. I play cricket always. Literally, this simple phrase is going to be your absolute best friend. It stands for inspection, palpation, percussion, and auscultation, IPCA. Whether you're dealing with an energetic toddler or a tiny, quiet newborn, this specific four-step sequence is the rock-solid foundation that ensures you never, ever miss a critical clinical sign.
Okay, let's dive into our game plan for today. We'll start with the respiratory system, move on to the cardiovascular system, work our way down to the abdomen, and finally, wrap up with the central nervous system.
Section 1. The respiratory system. This is truly the front line of pediatric care. Applying our trusty IPCA rhythm to the chest, we're going to move logically from just looking all the way to listening. First up, inspection. You're checking their work of breathing, looking for any cyanosis, and noting the chest shape. Second, palpation. Assessing the tracheal position and feeling for chest expansion. Third is percussion, gently tapping to hear normal resonance versus any concerning dullness. And finally, auscultation, grabbing your stethoscope to listen for breath sounds and any added crackles.
But here is where pediatrics becomes a totally different ballgame. Notice how the baseline shifts dramatically depending on the child's age. A newborn breathes anywhere from 30 to 60 times a minute. I mean, if we applied an adult baseline to that, we'd assume every single baby in the ward was in severe distress. Contextualizing these rates by age is absolutely vital to catching real red flags.
Now, what's really interesting here is when we reach that final auscultation step. The sounds you hear tell a very clear story. Normal vesicular sounds are soft, kind of like a rustling pitch. That's the sound of a healthy peripheral lung. But in stark contrast, bronchial breath sounds are harsh and tubular. Hearing those harsh sounds out over the periphery, that is a massive red flag for lung consolidation, like what you'd see in pneumonia.
Moving right along to Section 2, the cardiovascular system. We're talking rhythms, rates, and shifting baselines.
Once again, we re-anchor straight back to our core IPCA headings to assess the heart. Inspection, you want to observe the chest for precordial bulges or raised jugular venous pressure. Palpation, locate that apical impulse and really feel for thrills. Percussion, use this to map out cardiac borders, though full disclosure, this is notoriously less reliable in very young children. And auscultation, listening intently for normal heart sounds as well as any pathological gallops.
Let's check those cardiovascular baselines, and wow, the differences here are just staggering. A newborn's awake resting heart rate can sit anywhere from 85 all the way up to 205 beats per minute. No way, right? Compare that to a teenager who's sitting comfortably between 60 and 100. Just like with the lungs, keeping these shifting baselines top of mind is an absolute must.
For the auscultation phase, we need to take a rapid-fire anatomical tour of the chest. We hit some very specific valve areas: the mitral area, the tricuspid area, aortic primary, and the pulmonary area. We also definitely want to check Erb's point, and notably Gibson's area. Gibson's is absolutely crucial in pediatrics for catching the classic murmur of a patent ductus arteriosus.
Section 3. The abdominal system. Time to uncover the 5 Fs.
Okay, so the crucial point here is a bit of a plot twist in our sequence. For the belly, we actually have to alter our IPCA rhythm just a little bit. It becomes inspection, auscultation, then palpation and percussion. Why? Because we absolutely have to auscultate before we push on the tummy, otherwise we might artificially alter those natural bowel sounds.
Now, palpating pediatric anatomy can be tricky. Kids aren't exactly known for holding perfectly still, so here are 2 clever workarounds. First, the hooking method. You use deep breaths to effectively hook your fingers and feel the liver, which is great for older, more cooperative kids. Then there's the Middleton maneuver. This is a brilliant technique to palpate diagonally for the spleen, specifically because the spleen actually enlarges inferomedially. If we happen to suspect free fluid in the abdomen, our percussion step is what helps us confirm and differentiate the volume. Shifting dullness is what we use to detect moderate fluid, right around 500 to 1,000 milliliters, because it shifts with gravity. But for massive, gross ascites, we're talking 1.5 liters or more, we look for a fluid thrill.
That's where you actually feel a distinct physical wave of fluid travel right across the belly. And finally, Section 4, the central nervous system. Wiring, reflexes, and adaptations.
And this brilliantly illustrates just how versatile our framework really is. It maps perfectly to neurology. Inspection, we observe their motor gait, muscle bulk, and cranial nerves. Palpation, we're testing muscle tone, is it floppy or rigid, and sensory perception. Percussion, we're literally striking tendons with a reflex hammer. And yes, even auscultation. We actually use our stethoscope to listen for cranial bruits directly over the skull. Let's talk a bit more about the cranial nerves during that initial inspection phase. These are the 12 pairs of nerves emerging directly from the brain. Now, in adults, you can just give dry commands, but in children, testing their vision, facial symmetry, or tracking often requires some serious creativity. You basically have to turn the clinical exam into an engaging, fun game to get them to cooperate.
When we're evaluating the motor system, we need to cleanly contrast upper and lower motor neuron lesions. Just notice the inverse relationship here. In upper motor lesions, the tone is spastic and reflexes are super brisk, while muscle wasting is pretty minimal. But in lower lesions, wasting is pronounced, tone is completely flaccid, reflexes are absent, and you might even spot fine little fasciculations or muscle twitches.
For sensation and coordination, it's really all about a methodical checklist. We systematically assess superficial touch and deep sensation. We test cortical sensation, which is cool, like having them identify a coin placed in their hand while their eyes are closed. And finally, we check cerebellar coordination through finger-to-nose tests and by observing their gait. Obviously, all of this requires a ton of patience and age-appropriate instructions.
So we've successfully built a structured, visual map for pediatric assessment today. But here is the real challenge for you. Pediatric medicine is fundamentally defined by constantly shifting baselines. With this IPCA framework now locked into your mental toolkit, how will you adapt these steps the very next time you walk into a ward to examine a growing, changing patient? Thank you so much for joining me on this explainer, and as always, keep learning.